Okay, we're going to continue with the lecture. We'll talk about the ligaments and the muscles of the elbow joint. So the elbow joint itself is pretty fibrous. It has a thin capsule. It's pretty broad. It's very well articulated with the bone, and unfortunately is the joint that is most likely to get stiff on you. So we see this a lot with fractures or trauma, that this joint has a tendency to become very contracted. And so synovitis, synovial swelling among the elbow joint is pretty common. So understanding the orientation of the ligament and the capsules will help you hopefully prevent a stiff elbow. Has a pretty broad attachment. Is about 6 millimeters distal from the cornoid tip. It covers all three joints, so it has communication between the radial ulnar joint proximally and then the ulna and radiohumeral joints. So overview, it's a pretty broad ligamentous structure. It has a lot of connections anteriorly. The primary ligaments are the ulna collateral ligament and the radial collateral ligament and the annular ligament. But this connective tissue can be swollen and inflamed and irritated. Distally, you can see just below the capsule is the biceps tendon attaching to the bicipital tuberosity. So if we look at this from the lateral view, so this would be on the radial side, here you can sort of see the annular ligament. You have your radial collateral ligament. You actually do have a ulnar collateral ligament that attaches on the lateral side. As it comes here, I have some better pictures of that. And then on the medial side, you get the big triumphant ulnar collateral ligament, which is broken up into different components. This is the big, most important stabilizer on the medial side. This is the anterior bundle. This is the transverse or oblique, and then you also have a posterior bundle. The oblique or transverse cord bundle runs from ulna to ulna, so not as critical in the stabilizer. But the anterior band and the posterior band provide a lot of stability on the medial side of the elbow. You can see the triceps coming down. I've got a better picture of the triceps and muscles. It's quite a broad attachment. And then the infamous subcutaneous olecranon bursitis that can get really big on you, look like a baseball swollen if you happen to land on your elbow. So these are percentages of stabilizing structures at the elbow joint when the elbow is in full extension and when the elbow is at 90 degrees, so in a flex position. So you can see the contribution of the elbow primarily in full extension is going to come from the capsule and from the bone. Capsule in your distraction, varus and valgus is going to come with the bone. You certainly do get some load on the valgus ulnar collateral in full extension, a little bit more even from the joint capsule, and then limited to no support from the lateral collateral. Now that significantly changes when the elbow is bent. So now when the elbow is flexed, you lose some of the stability from the joint articulation with the elbow flexed, and more load is put on the UCL. Again, some stability from the lateral collateral for distraction and varus. Again, not very much. The general joint capsule carries a little, and then the articulation carries a lot. But a lot more emphasis when the elbow is slightly flexed or more flexed, so it jumps from 31 to 54. As I said before, we have a hinge joint, and so we have to have collateral ligaments just like the medial and lateral collateral ligament in the knee. You need to have medial and lateral collateral ligaments of the elbow, except we call it ulna and radial collateral. The lateral collateral ligament, as I said before, here's the annular ligament, a little bit better picture. Radial collateral ligament coming into the radius, and then a lateral ulna collateral ligament running into the distal ulna. So this LUCL. So when you dislocate your elbow, often what happens is these ligaments tear first, and then it works its way around toward the medial side. That's a posterior lateral rotary instability, but it's very common that if you sublux or dislocate your elbow and it's maybe partially displaced or perched, typically what gets torn first are these radial or lateral collateral ligaments. And then you obviously have an annular ligament. Usually with elbow dislocations, you don't always necessarily dislocate the annular ligament, but you can. And then we have the infamous medial side. This is the three primary parts of that. So we've got the anterior, which is the main stabilizer and is the ligament that gets reconstructed with the Tommy John procedure. You have the oblique or transverse, and then the posterior. That actually was reverse. So this is the posterior, and this is the oblique and transverse. Sorry about that. Didn't catch that. So it doesn't matter what you do, but a valgus overload can load the elbow. We don't see this as commonly, but it certainly can happen that you can put excessive valgus overload into your elbow. More commonly, what we see this is with our throwing athletes, particularly our pitchers. And there was a lot written in Sports Illustrated and other journals, medical journals and magazines about how common Tommy John procedures are getting done now. The primary mechanism of injury is this repetitive valgus overload, and it's not from one mechanism, one time, but it's this gradual microtrauma. So the MCL, or the ulnar collateral ligament, gradually becomes stretched out, and then maybe there is a final straw that breaks the camel's back, and they have a disruption. But it's a gradual overload. Other structures can be involved and have to be ruled out, primarily the pronator teres, which is directly over the ulnar collateral ligament. It can provide some stabilizing as a dynamic stabilizer, as well as some of the other wrist flexor and finger flexor muscles. So the other thing that we forget about is that when you go into valgus, you're also getting impaction on the other side. So they might present with lateral or radial side pain because they're getting too much compression on that other side, on that radial side. So you can get articular cartilage damage, you can get necrosis, you can get a bloody avascular necrosis of the radial head, you can get osteophytes building up, all kinds of things can occur. And so when you think valgus, you need to not just always think on the medial side, but their pain could be on their radial side or even posteriorly, because we have compression on this side. The other thing that can happen is this posterior impingement, where the olecranon, because of this increased mobility, now this olecranon is not fitting directly into the bony congruence that was originally developed for it, and so you have the olecranon sort of rubbing and irritating this other medial aspect of the distal humerus. So a medial olecranon process on the posterior lateral edge of the olecranon fossa can irritate, inflame, and cause discomfort. Might need to be surgically removed if an osteophyte develops there. And then obviously, along with ulnar collateral ligament damage, you can also damage the nerve and have ulnar neuritis from excessive stretching or inflammation in that area. So there's a lot of pathologies, all from valgus loading, and it's not all a Tommy John injury, but the mechanisms are all the same. So mechanism of injury may be similar in all of those diagnoses, so you really have to do a thorough examination. You have to look for loss of extension, you have to look for localized tenderness, you have to do passive and active and resistive activities to differentiate ligamentous versus muscle versus neural injuries. So even though it's not a very complex joint like the elbow, or like the shoulder, it still requires good attention in your physical examination of these. Okay, let's talk about the muscles. There's 9 muscles that cross the anterior aspect of the elbow. 3 of them have a primary function at the elbow joint. Those are the brachialis, biceps, and brachioradialis. The brachialis and biceps are the primary elbow flexors. We know that the biceps has an additional role that helps with supination of the wrist, and then the brachioradialis. Also helps with flexion. It's oriented to be more of a stabilizer. These two are oriented more for allowing motion at the elbow joint. The other functions, two have primary function at the proximal distal radial ulnar joint. The biceps helps with supination, the pronator teres, and to some degree the pronator quadratus help with pronation. And then we have four extrinsic hand muscles that all arise from the medial epicondyle. They sort of have a common attendant. One's primary function is at the wrist and hand, and then the other ones are sort of weak elbow flexors and help to stabilize with varus and valgus load, primarily valgus load. So here we can sort of see the orientation of the biceps, its distal attachment to allow for, when it contracts, it's going to facilitate rotation of the radius on the ulna for supination. Don't forget the biceps also has a short head that goes to the coracoid. So we have a long and a short head. Then we have this deep muscle. This is the brachialis. This is attaching on the ulna side. So it's one of the short, it's only a one joint muscle versus a two joint muscle. And so those are most common site for a biceps tear is distal tendon with those activities. Here you can sort of see the brachioradialis coming down along on the radial side. This muscle is often used as transfer if we lose function of some other proximal muscles. If you remember back to your neuro exam, this is a radial nerve muscle, not a musculocutaneous nerve. So in the case of a injury to the musculocutaneous, it becomes a very important muscle in functioning. Here you can see a little bit better how it sits on top of the extensor carpi radialis longus and brevis. So as the three of them together are called the extensor wad. So if you go to make a fist and start to flex your arm, you can sort of see that extensor wad pop out. Elbow flexors, primary role is going to be to bend your elbow. It's going to help to stabilize and facilitate activity. Shoulder extension facilitates more use of the biceps to flex the elbow. So if you bring the elbow back into more shoulder extension, you're going to facilitate bicep activity. Slightly supinated facilitates biceps activity. Brachioradialis and brachialis minimally affected by pronation and supination. So this idea of getting more activity with the arm, pronated or supinated, doesn't seem to have a huge effect on brachioradialis or brachialis. So the small anterior muscles of the elbow, the pronator teres, it's sort of these four muscles. Pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris, all sort of line up along your four fingers. In the extension, you have the big tricep and you have the anconeus muscle. So the tricep is broken up into three heads: the long or central, medial, and lateral head. The anconeus, in dissection of cadavers in two different studies, found that 40% of the cadavers were found to show the anconeus was continuous with the lateral head of the triceps. So some physicians, some doctors feel like it's not really a separate muscle, but just a different extension of that. So here's a better picture. This is from a cadaver dissection in a recent research study. So we all sort of think of the triceps as this common tendon at the olecranon, but you can see this lateral triceps is definitely not directly attaching into the olecranon and is coming down into anconeus. So here's a representation of where these are almost continuous muscles. So portions of the tricep definitely attach to the olecranon, but it's a pretty broad muscle in its attachment. So we've studied the tricep function looking at three different heads. We looked at the anconeus, the medial and lateral, medial and central head, and so we looked at some functional activities. We found the greatest muscle activity near full elbow extension. This is an MVIC, so if you really want to get a lot of muscle activity, you need to get them close to full extension. We found that the medial head is thought to be the workhorse of the elbow. Only when loads are heavy does the lateral and the long head really get recruited. So the medial is a primary. We looked at functional activities of lifting weights overhead, placing them up on a shoulder or a shelf. We did overhead reaching activities with different loads. We did a skull crusher or supine extension. We also did pushing activities. The skull crusher was used with different loads, elbow flex. The little styrofoam block prevented them to go into too much elbow flexion. So we found that there was an interaction between muscle by angle. We did Bonferroni post-hoc analysis and revealed that the medial triceps significantly increased its EMG activity over the last 30 degrees. Very similar to the VM in the knee. In that last 30 degrees, as it's locking out, there was more muscle activity of the medial aspect of the tricep. The Bonferroni analysis also revealed that the medial and lateral were much more active than the central portion of the triceps. So central is blue, very low activity. This is skull crushers, different. This is across all three loads, so supine extension or skull crushers with 95% confidence intervals, and we found that the lateral and the medial portion were always significantly higher, and then you can sort of see this uptick in the last 30 degrees where the medial portion gets even more active in that terminal elbow extension. We looked at pushing activities with multiple loads, again 0, 1, and 2, nothing super heavy, saw the same phenomena. Central very low, medial and lateral most active with a big increase in medial activity as we go through that last 30-degree arc of motion. So the explanation for this is that the lever arm is longer in extension, therefore greater muscle activity is necessary to move the arm. So obtain lockout to fully extend against gravity is challenging in rehabilitation. So it's definitely something that's hard to re-accomplish, and so we really got to make sure we're working on elbow extension and particularly activating the medial triceps as we rehab patients. Pronation and supination are controlled by muscles around the elbow. Supination is going to be affected primarily by the biceps, and then you have this deep muscle called the supinator. The supinator has another unique capability. It can affect the radial nerve, so it can mask as lateral epicondylitis if this impinges the radial nerve, if this is too tight. In some cases, you'll have the radial nerve coming out at the bottom or in the middle of that muscle, and so that's a potential nerve entrapment site is along the supinator. Supination gives you high torque capabilities, so biceps when the elbow is flexed, it's going to help generate greater torques. In extension, it's a little bit more on the supination. So helps with activities of daily living. Other muscles that can help with supination: wrist extensors, extensor pollicis longus, and extensor indicus, and the brachioradialis. Pronation is primarily by the pronator teres and then the pronator quadratus. The pronator teres is the prime pronator, regardless of elbow flexor extended. Remember, if you flex the elbow significantly, you might be biasing the pronator quadratus a bit more. Secondarily to that are the flexor carpi radialis, palmaris longus, and brachioradialis. Oops. Oh, these are just outlining the muscles: pronator teres, flexor carpi radialis, and palmaris longus. Okay, and then here's the picture I showed you before, the pronator quadratus. So, sorry I couldn't be in class today, but I'm going to pay my respects at the Houston Society meeting. This is Dr. Jack Houston, one of the fathers of sports medicine. He helped write some of the original research on knee ligament reconstructions and was the gentleman who I had the pleasure of working for about 5 years. Learned a lot of knowledge that I'm happy to share with you guys, and started the American Journal of Sports Medicine. That is all.